Dr. Vidya. I invite Dr. Rathini, Senior Consultant in Glaucoma Services, and she did her long-term fellowship in Shankara Nethralaya, Chennai, has several publications to her credit, including chapters and books. She has also won the Best Paper Award at GSI twice in 2014 and 22, and her clinical skills and approachable nature has made her a go-to person for all glaucoma trainees during and even post-fellowship. Over to you, ma'am.
Good morning, one and all. My topic for today is the ups and downs, progression of fluctuation, mastering the glaucoma progression analysis. Estimation of threshold sensitivity in visual field testing is not perfectly repeatable, and it's often affected by variability. Variability is often a confounder of progression. So coming on to a bit of a background, where you have to know a certain terminology like the noise, which is a physiological background noise in the visual system against which a stimulus signal may be detectable, is quite variable, causing threshold variability. The factors causing noise are neural noise, cognitive function, decision criteria, and threshold strategy. Other factors which can affect threshold sensitivity are the overall degree of visual field damage, the degree of damage at a particular location, and the eccentricity of the particular testing location. So how can we quantify this variable? Intensive sensitive psychophysical tests have been conducted, and the frequency of seeing curve has been plotted. The points along this frequency of seeing curve at which 50% of the stimulus are detected represents an accurate measure of the threshold, with the slope providing a measure of the intra-test variability. So steep slopes signify low intra-test variability and shallow slopes signify greater variability. Eyes with advanced glaucoma show greater variation, which may not be due to fixation errors, but may be mostly due to atypical firing characteristics, damaged retinal ganglion cells, and a lower ganglion cell density. Other ways of quantifying variability would be the long-term and short-term and long-term fluctuation. Short-term fluctuation is a simple global index which is derived from multiple threshold estimates made during a single test, and it's a clinical equivalent of intra-test variability. Long-term fluctuation is calculated mathematically from multiple visual field examination. It's not available on a commercial instrument, and it is a clinical equivalent of an inter-test variability. Another alternative method of quantifying variability is the test-retest variability. It quantifies the scatter of measures made on one or more examination at different test locations. So variability, unlike the psychophysical test, variability can also be investigated based on data gathered with test strategies designed for rapid estimation of threshold, which is suitable in clinical environments. So variability may occur due to instrument design and thresholding strategy. For example, if we take full threshold versus fastback strategy, we find that the full threshold tends to exhibit lower variance than the fastback because of its Ripple criteria. A size 5 stimulus also would exhibit lesser variation. So what is progression then? The defects must be repeatable and reproducible in the same location, and it must exceed the test-retest variability. So coming on to a little about the rate of progression. An average rate of progression of visual field in a treated glaucoma patient would range between minus 0.05 decibels per year to about minus 0.6 decibels per year. And the rate of loss due to age would be accounted by minus 0.06 decibels per year. For a past progressor, would typically exceed more than minus 2 decibels per year. So according to Chow et al., they found that to detect a decibel change of minus 1 mean deviation, we have to at least do 7 fields in 2 years to pick up progression earlier. The EGS and the World Glaucoma Association consensus also recommend 3 visual fields per year, including the 2 baselines, so at least 6 fields in 2 years. So the progression analysis can be done non-statistically and statistically. Non-statistically would be by clinical judgment, and statistically by defect classification system, event, and trend analysis. So coming on to clinical judgment, it consists of a simple subjective observation of sequential visual field tests. So the advantage of it being it's easy to perform, no additional commutations, and it's quite flexible. Disadvantage is that it's subjective, non-statistical, and non-standardized. According to Vishwanathan et al., they found that when 5 expert clinicians graded 27 visual fields, with no guidelines, only based on the perimetric output, there was a fair inter-observer agreement with a kappa value of 0.32. The overview report makes it simpler, puts together all the patient's available visual field into a single report. The overview printout represents the grayscale, the decibel sensitivity value, the global indices, and total and pattern deviation plots across a series of visual fields. So this is an example of an overview printout, which gives you all the visual fields in one look. So this is another example in which patient had a cataract, so you can see the depressed total deviation and the pattern deviation, and after cataract surgery you can see that all these defects have disappeared in the last report. So defining progression. So the early manifest glaucoma trial defined visual field progression as significant change from baseline on at least 3 locations on 3 consecutive visual fields. This criteria is a glaucoma change probability, and these criteria has been incorporated into the GPA. The other systems of classification are based on the Advanced Glaucoma Intervention Study and the Collaborative Initial Glaucoma Treatment Study, where there is a scoring system between 0 and 20, 0 being normal and 20 being the worst field status. They were both based on total deviation maps. The EMGT criteria definitely detects progression on an average of 1 year earlier than the other 2 criteria, and there is only a fair to moderate agreement among these criteria and clinical assessment. So coming on to event and trend analysis. The event analysis compares all points on the visual fields to 2 baseline visual fields to assess if progression is present or not. So the GPA compares each consecutive test to the baseline point by point to find any deviation beyond 95% confidence interval for expected test-retest variability. The GPA uses the same criteria used to define progression in the EMGT study. So selection of baseline is very important. 2 baselines which are reliable have to be chosen which have been done within 6 months. And it's also important to remember to change the baseline following any intervention performed. The GPA performs a progression analysis probability plot where it compares the baselines with the current visual fields and gives you a probability plot with a small open triangle indicating a degree of deterioration expected less than 5% of the time at that location. A half-full triangle indicates significant deterioration at that point in 2 consecutive tests, and a solid triangle indicates significant deterioration at the time in 3 consecutive tests. And X signifies that the data at that point was out of range for analysis. So it also gives you a GPA alert. So the possible progression is when 3 same points show worsening in 2 consecutive tests, and likely progression in the same 3 points show worsening in 3 consecutive exams. So Arnalik, Monitel et al. Said they found that the possible progression criteria achieved a sensitivity and specificity of 93 and 95% respectively, and a positive likelihood ratio of 20% based on a thorough objective clinical assessment. The advantages of the GPA, it is not greatly affected by media opacities and refractive errors. The disadvantage being that it is difficult to identify progression in patients of glaucoma with diffuse loss, and its usefulness is also limited in advanced glaucoma when it's severely depressed beyond minus 15 to 20 decibels. And an additional software is of course required. The Forum CS software allows access to visual field data from multiple HFM devices. Visual field index, as we've already been talked about earlier, it is mostly based on pattern standard deviation and it's more center weighted. However, in advanced visual field loss, the total deviation values are used instead of the pattern deviation values. So in trend analysis is a linear regression analysis of global indices such as VFI and mean deviation. In GPA2 performs a linear regression analysis of VFI over time. So at least 5 to 6 visual fields over 5 years is required to achieve a good performance. It also gives you a slope of regression with the whether it is significant or not with a 95% confidence interval. So you can see here. So this is a regression analysis that has been done, which shows the current amount of visual function of the patient, and it also gives you the prediction of the VFI for the next 5 years. And this is the estimated rate of change. So the GPA2 in the Humphrey visual field is the most commonly used progression software. GPA2 provides both event and trend analysis. It supports strategies like CETA standard and CETA fast and programs such as 24-2, 30-2, but not 10-2. So this is how a full summary looks like. So you can see the 2 reliable baselines followed by the VFI regression analysis with the rate of progression. Then you have the present visual field progression analysis, and with the GPA alert at the bottom. So Casas, Lera et al. Found that GPA2 detected progression in 16% in which trend analysis had failed and detected the progression 6 to 8 months earlier than visual field index. So these are few examples in which you can see that both the event and the trend analysis are fairly stable over time. And this is another example where you can see slow progression occurring in the trend analysis and also in the event. So this is another example where the trend is stable, but however the event is showing some a likely progression. This is another case where both the trend and the event are progressing. In this also you find both the trend and the event progressing. So another way of assessing progression would be to do trend analysis by using clusters. So Crabb et al. Proposed a wait-and-see approach in which visual fields were clustered at baseline, then again at the end of 2 years, based on computer simulations. Improved detection of progression. It is definitely improved detection of progression than testing at regular variables, and it also reduced the false positive rates. The logic behind it is that the data near the beginning and the end may influence a trend analysis more than doing it at regular intervals. So how do we assess progression on 10-2? So we know that the central vision is affected early in glaucoma, and that is not so uncommon, which can ultimately affect the macular function and the quality of life. Currently, there is no available commercial software for detecting progression in 10-2. T. Morris et al. Developed and validated a set of criteria that uses point-wise linear regression analysis of the threshold sensitivity data to detect progression. Park et al. Also retrospectively studied 50 eyes with parafoveal scotoma with longitudinal 10-2 and 24-2 perimeters using point-wise linear regression and detected progression in 24 eyes with 10-2 visual fields. And among these, progression was missed in 17 eyes using the 24-2 visual fields. So take-home message, detecting progression still remains crucial for glaucoma management, and it's also an important for us to decide on stepping up treatment. No single method may be absolutely reliable, and lack of gold standard is a major disadvantage. With the GPA, in short, the event analysis may alert the clinician of the onset of a change, and the trend analysis assesses the rate of change. Thank you.
Thank you, ma'am. Invite Dr. Kiran.